Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine for our patients, our members, and the communities we serve. Thanks for tuning in.
Hello, and welcome to the latest episode of the POMA Does podcast series, sponsored by the Pennsylvania Osteopathic Medical Association. I'm Lisa Witherite Rigg-DO, the immediate past president of POMA and the champion of the education pillar. Today, we are going to provide an overview of RSV and influenza in our adult patients. We will discuss these two viruses, symptoms patients may experience, special considerations among our adult patients, available immunizations to help protect against severe infection, and what we, as physicians, can do to best care for our patients. This podcast is eligible for CME credits. To claim your credit, visit the webpage noted in this episode's description or visit the POMA Does podcast page on the POMA website. This podcast is supported with the grant from the American Osteopathic Association. The Pennsylvania Osteopathic Medical Association, along with other osteopathic state and specialty organizations, have collaborated with the AOA to provide education to physicians and their patients regarding public health concerns, such as RSV, influenza, and COVID. This podcast episode was developed entirely by POMA. None of the panelists or planners for this episode have any conflicts of interest to disclose. I'm privileged today to be joined by Dr. Angelo Aluzzi and Dr. Grant Shermer. We'll first hear from Dr. Aluzzi discussing respiratory syncytial virus. And Doctor, now I ask you to please introduce yourself to our audience and share a little bit about what you do.
Good morning. I'm Dr. Aluzzi, Angelo Aluzzi. I have been in practice for over 40 years, primarily pulmonary medicine and sleep medicine now. So we're always involved in patients who have respiratory tract infections. We do see a lot of it, especially in our COPD population, obviously involving adults. But respiratory syncytial virus, you have to talk about children to some degree because the two are obviously intermingled. So the virus was first identified in 1956. It was found initially in chimpanzees. In 1957, they discovered it in children who had upper respiratory illnesses. So we've known about this virus since the mid-1950s. We've had 70 or more years of it to deal with it, and it is a very common infection. What exactly is it? It's an RNA virus. It's a negative sense, single-stranded RNA virus, and we have to get into the molecular biology of this a little bit. So in molecular biology, the sense of the genetic material, the nucleic acid molecule, particularly of a particular strand of DNA or RNA, refers to the nature of the roles of this strand and its complement. In other words, what's its opposite in specifying the sequence of amino acids. So not a complicated virus, but obviously one that's highly prevalent. We'll discuss the symptoms a little bit. Seasonally epidemic, usually from November to April. That's when it peaks. It's human RSV because there are other forms of respiratory syncytial virus. An infection could present with a range of severity from mild upper respiratory tract infections to severe lower respiratory tract infections. Sometimes they can be life-threatening in individuals and sometimes even requiring mechanical ventilation. Human RSV can cause respiratory tract infections in people of all ages. So it goes from infancy to the elderly. It's common among children and very common respiratory tract infection amongst children. Presentation varies between the age groups and also in the immune status of the individual. Reinfections common throughout life. So if you had it once, you're likely to get it again. Infants and the elderly remain at risk for symptomatic infection. Children, we have to discuss that because they're obviously intermingled with adults, and with the infection, they're a common form of transmission. Nearly all children in the United States will have experienced at least one human respiratory syncytial virus infection before the age of 2 years. So very common in infancy. Infections tend to be self-limited. You'll see cough, nasal congestion, runny nose, low-grade fever maybe, rhinitis, pharyngitis, and sometimes even just conjunctivitis secondary to respiratory syncytial virus. In about 15 to 50% of children, it'll go on to develop or serious lower respiratory tract infections. So most commonly bronchiolitis, talk about that, viral pneumonia, or croup, and infants are at the highest risk of disease progression. Bronchiolitis, very common disorder, especially in children. It's a respiratory tract infection, which is characterized by inflammation and obstruction of small airways of the lungs. So people think of the lungs and bronchitis and alveoli. This involves the very small airways proximal to the alveoli, which is an extremely common area for respiratory tract disease to occur. It's usually where the virus attacks. And when they become inflamed, obviously they become obstructed of a relatively small diameter of the airway. So that's what causes significant problems, similar to other viral pneumonia. So COVID, similar to that, other viruses.
So, Dr. Luzzi, you said that most kids, and we'll talk more in another podcast about the children specifically, that most kids will experience in their first 2 years of life. Does the virus change like we see influenza changes and we see COVID has changed many times? Does RSV change?
We'll discuss that
Very
in
good.
a little bit.
Okay.
It's responsible for 70% of cases of bronchiolitis. And like I said, you'll see cough, noisy breathing, tachypnea, wheezing in some children, occasionally fever. Sometimes they have issues with deoxygenation. So when you and I were training
Many years ago.
in history, I remember being on the pediatric wards and you saw a lot of kids in the oxygen tents.
Right.
And they had the big mist thing going, remember that? And they'd be sitting in the cribs and playing with their toys and coughing their little heads off. And, with that croupy cough, those children most likely had RSV. And really, even in those days, we didn't have much to treat them with. And we'll discuss a little bit about the treatment today that's available.
Even a way to test them.
You didn't have a way to test them, right? No polymerase chain reaction studies at that point.
We're showing our age.
Yeah. When we were well, we could say it's a virus. Now you have a panel of about 40 different viruses that they check, especially today where people show up with a viral illness.
Yeah.
They'll do a respiratory panel or a nasal swab for influenza, COVID, RSV, but then you could also get, human rhinovirus. Oh, God.
Well, people want to know.
Yeah, people want to know. Well, the doctors want, I think, more than the patients want to know. They know it's a virus. Most of the time, self-limited. Most of the time, you can't do anything about it. And, my point, you're spending a lot of money to find out something that you can't really do much about it and it's going to go away on its own. In premature infants, the symptoms can be less specific. So decreased activity, irritability, poor feeding, and breathing difficulty. In adults, reinfection remains common throughout life. So if you got it last year, you might get it next year. In adults, the symptoms usually mild, common cold symptoms, sinusitis, rhinorrhea, pharyngitis, fever, malaise, or you might be totally asymptomatic. It varies with the individual.
That asymptomatic could really enhance the spread.
Yeah, well, just like COVID did in asymptomatic patients. Or the early phases of influenza when you're relatively symptomatic. On day 1, on day 2, you get hit with the chills and the fever and the muscle aches. It can cause new onset wheezing in adults, so that we need to realize 25% of adults will progress on to local respiratory tract infection, namely bronchitis and tracheobronchitis primarily. RSV very rarely causes severe disease in healthy adults, and I know you need to discuss it.
Yeah, so last fall, my granddaughter had RSV, a toddler, and my son, who is very healthy, ended up with RSV pneumonia.
Was he hospitalized?
No, was not hospitalized.
So oxygenation wasn't an issue.
No.
And then again, he's just got to get over it.
Yeah.
In the elderly or immunocompromised patients, the risk of pneumonia, respiratory distress, that they're much more likely. So those are the people that, in adults especially, and we worry about, and there are a lot of them. Immunocompromised patients, both children and adults, are more likely to progress from upper respiratory tract disease to lower respiratory tract disease with a prolonged period of viral shedding. So they cannot knock out the virus as a patient with a normal immune system.
So that 7 to 10 days can progress to weeks.
Longer than
weeks.
that. Yeah. Those who have undergone hematopoietic stem cell transplants, otherwise known as bone marrow transplants, or any person who has undergone intensive chemotherapy or a lung transplant are very susceptible, particularly susceptible. Bone marrow transplant patients appear to be at the highest risk, especially if it is immediately after the transplant and prior to engraftment is when they are at the greatest risk. And about 80% of them have the risk of pneumonia or death. So those are the individuals that are particularly we are concerned about.
So you get a double whammy when those folks have those transplants during RSV season,
Right.
that November to February window.
Well, it's November to like April.
November to April now.
So that's something that would be a great concern for
Sure.
the transplant teams. And everybody sees them, no matter what your practice. They're going to oftentimes call their primary doctor with respiratory tract illness or what they deem a viral illness, who has to be in tune to this, know the patient, and if they've undergone a transplant for whatever reason it might be, cancer, aplastic anemia, and they're around, you gotta be aware of that. You can get really sick and die.
So that's where that osteopathic component to our training, that treating the whole patient and
gotta know
everything, and be able to incorporate that into your care and your planning for that individual.
You have to know your patient. You have to know their disease process. You have to know what their risks are. You got to know, it's not an easy job. You have to know everything, and it's kind of forgotten today. So what's the virology of a respiratory syncytial virus? It's divided into two different antigenic subtypes. There's an A and a B, and it's based on their specific reactivity, and I'm not a basic science person, of the F and G surface proteins to specific monoclonal antibodies. So that's how they separate. RSVA, more virulent than RSVB. Higher viral loads usually you'll see in a faster rate of transmission of the virus. To get back to your previous question, RSV cannot participate in the type of genetic reassortment like COVID did and antigenic shifts responsible for large pandemics. So you'll see people get sick. You might see a small, brief epidemic. You're not going to see what we witnessed with the COVID virus. Prevention, we have to talk about that. How do you prevent this? Well, you get back to the basics with RSV. So it's hand washing, it's avoiding patients who are sick, close contact with infected individuals, and cough covering. And my comment regarding that is, go to a daycare, go to a preschool, kindergarten, go to elementary school, go to high school. There's always close contact, right? These kids are swapping bodily fluids all the time. They're little petri dishes of various infections, not just RSV, influenza, the common cold. We won't discuss COVID, other things.
In our days, it was chicken pox and
measles, mumps. Remember the chicken pox parties, which are good ideas.
Vaccines are good ideas.
Yeah, the vaccines are good ideas. Chicken pox parties are not good ideas. Yeah, with kids, obviously, it's hard with toddlers, especially in a daycare setting. They're in close proximity. They're in an enclosed space. They're touching, they're talking. It's hard to teach a 2-year-old to cover up their cough or coughing to their elbow. Obviously, I had an elderly patient here yesterday who had RSV because he colored from his grandchild. In today's society, we see a lot of grandparents providing care for their grandchildren. This is a common social problem. Adult parents can't afford childcare.
Yeah.
They have to work. And oftentimes, grandma and grandpa are the backup, this, and they take care of their grandchildren. So they may do that 5 days a week. Sometimes the kids are in preschool, sometimes they're in grade school, but when they get home, it's grandma and grandpa.
And sometimes they're homesick.
Sometimes they're homesick, and grandma and grandpa are exposed to all that. So you might as well put grandma and grandpa right smack in the middle of that group of kids, but we're all coughing and sneezing and, swapping bodily fluids with each other, so to speak, who are now susceptible. Now that brings us up to what else can we do, right? We're talking about now vaccines. So in infants, there are infant-specific factors such as immature infant immune systems and presence of maternal antibodies in an infant that will make vaccine administration difficult. And I'm going to talk about the vaccines. They've tried live attenuated vaccines, and they've shown some promise. However, they have to be RSV naive infants in and of themselves. That's a rare breed. Most of them already had me by the age of 2. So for infants, how do you try to prevent disease, especially early in life? You have to vaccinate them. So vaccination of pregnant mothers can confer immunity to infants with about 82% effectiveness at 3 months and about 69% efficacy at 6 months. And that's why this gets to be a big issue with the vaccines themselves. We'll talk about that. Vaccination is advised by the CDC for adults over the age of 60. They don't specify anything else.
All adults.
All adults.
Doesn't matter their risk.
Doesn't matter their risk. Doesn't matter how healthy they are.
Okay.
If you're over 60, you should be getting vaccinated. And Healthcare providers are also advised to get RSV vaccine. So if you're a nurse, you're a doctor, you're an aide,
So regardless of your age.
nurses, regardless of your age, the healthcare provider should get vaccinated because they have high exposure rates.
Right. I would think teachers would be in that
Teachers
category.
a bad idea.
But the
They don't
coverage,
specify.
yeah.
Yeah. And again, insurance coverage is an issue. So especially in these vaccines today,
they're about $300 a dose. Yeah.
I can talk about that too, because try to provide it in your office. You don't know what the coverage is going to be.
Right.
You know, you're going to get that phone call saying, I have to pay $200 for a vaccine. What did it do for me? I've been referring patients to pharmacies because they have better ways of checking what their coverage is. So pregnant women at the age of 32 to 36 weeks in gestation from the months of September to January are advised to get the vaccine. And why is that? It's for them, but it's also for the child. So that by the age of 6 months, they still have 69% efficacy in terms of protection from the virus. So the early months of life, infants mostly susceptible, you'll have some protection. So after vaccination, we're going to get into some treatment options, which are in healthy adults really limited. It's primarily supportive care. You got a cough, you get cough medicine, nasal congestant, you get a decongestant. Everybody knows what they do if they get a cold, or if they get an upper respiratory tract infection.
And antibiotics only if there is a proven secondary bacterial.
I know antibiotics sends the patient out of the room with a smile on their face, but it doesn't do anything for them. And most of the time, the majority of the times, you're dealing with a viral infection. Every so often, you might get, stung with a Legionella or, mycoplasma infection or even coccal infection. But in those cases, you got to just, keep a keen eye and a keen ear on what's going on with the patient.
Back to our osteopathic tenets, the body inherently has the ability to heal itself. You just have to help that patient maximize good nutrition, adequate hydration, avoiding other exposures if possible.
Right. And I'm a big believer in de-escalation of medication.
Yes.
And also the whole holistic approach. And I always had that, because I educated years ago. My professors, especially in osteopathic medical school, were guys who had already been in practice for like 30 or 40 years. And, they went back to the 40s and the 50s, and they really pounded that into us. And even though, I'm a specialist and have done pulmonary medicine for years, critical care medicine for years, sleep medicine now for years, I always get back to those roots.
Osteopathic physical.
Right. You need to know everything about everybody that you are seeing, whether you're a single organ specialist, a primary care physician, whatever it is you do, one thing's connected to the other, foot bone's connected to the ankle bone, and it's all one body. So it really is necessary for you to stay keen. So if you have RSV bronchiolitis, primarily, again, supportive care, especially children. Hydrate them, because that becomes a problem with kids. They tend to underfeed and they tend to become dehydrated. That can make their situation worse. If you have to give them oxygen, we give them oxygen. Remember the old good old oxygen tents and the misters. I remember that, the misters.
Blow-by.
Yeah, blow-by mist and, all that we used to do. Associated RSV, associated bronchial hyperreactivity. So this is something that occurs in some individuals, not everybody. And how's that manifested? It's primarily, like we said, wheezing. So you could see wheezing in a child, you can see wheezing in an adult. Again, bronchiolitis, narrowing of the airways. You're going to see, higher flow rates in the airways. This gets down to the basic physiology and physics of the respiratory tract. And those patients might wheeze. And in those individuals, you might see some benefit with the addition of steroids and bronchodilators, only if they're hyperreactive. We don't give it to everybody. Again, overutilization of medications.
And that can further suppress
steroids can cause, Now, short term, you're not going to see much immunosuppression. I always tell people, you're not going to see immunosuppression unless you're on high dose steroids for about 2 weeks. So this tapering of steroids during COPD exacerbations and all this other stuff.
Doesn't
make sense. In older children and adults, especially if there's a history of asthma or viral infection could be resulting in a major exacerbation, then you're going to want to consider those things. You maintain their treatment regimen for their asthma. And if you have to, you can add corticosteroids systemically or increase their inhaled corticosteroid during an acute infection. And in some people, now you have the option of using combination bronchodilator, inhaled corticosteroids together in the same device for short periods of time to sort of get them over the hump. There was, and I won't use any names, but there was recently a combination of budesonide and albuterol released on the market, and I'm sure they're in the offices of all the primary care people discussing this agent, and that would be probably a scenario in which you would consider short-term use. Yeah, even just like 3 or 4 days.
Okay.
And we do this with kids. I mean, because I do treat kids with asthma. If they come in and they have a viral illness or they have an exacerbation of their asthma, whatever the cause might be, we will sometimes not use systemic corticosteroids, but we will use a higher dose of inhaled corticosteroids for 3 to 5 days. Okay, so you avoid the systemic corticosteroid side effects and, you still get some benefit from it. Now we have to deal with immunocompromised patients because those are the ones really that are at high risk, and those are the ones that you're really sort of the front line for.
And it could be really scary.
Oh, yeah. Well, COVID kind of proved that.
Yeah.
So individualized treatment for each patient. Again, you're not going to, paint a broad brush, which is what happened with COVID, actually. So the optimal treatment, nobody really knows. You got to consider single agent or combination therapy. So what's available out there? Ribavirin, IVIG, intravenous immunoglobulin. There used to be an RSV specific IVIG. It's no longer available. So now it's just IVIG and palivizumab, which is Synagis. Palivizumab is a monoclonal antibody. We'll talk about that. Plus or minus a steroid. Again, the steroid thing, if they're wheezing, if there's evidence of, bronchoconstriction, it may, an inflammation, it might be a consideration.
And these are all hospitalized patients at this point.
At this point, yeah, you're probably in the immunocompromised. You're not getting any of this. Palivizumab, it's a monoclonal antibody. It's indicated for the prevention of progression to severe disease in high-risk infants. So if you're using it in an adult, it's off-label. Who are the high-risk infants that you worry about? You worry about preemies under 35 weeks gestation. You worry about 2-year-olds or less who have had bronchopulmonary dysplasia, which is not commonly seen anymore, really. We have seen adults who've had bronchopulmonary dysplasia because of their experience in the NICUs in their early ages. Neonatal medicine's come a long way. And if they've had bronchopulmonary dysplasia, if they're under 24 months of age, and if they've had to have medical therapy within the previous 6 months related to that bronchopulmonary dysplasia, those are people that those are children that you would consider the therapy. And any child under the age of 24 months who has hemodynamically significant congenital heart disease, those are the preemies or the children that we would consider treatment for. There's no data for combination therapy. So, ribavirin plus palivizumab, nobody knows.
We don't know.
There's no randomized clinical trials. So if you do it, it's going to be an adventure possible. Special populations, again, hematopoietic stem cell transplants, bone marrow transplant patients. So they have a 70% mortality rate if they get a lower respiratory tract infection with pneumonia. So
that's horrid.
Remember, it is hard.
Yeah.
That's why they worry a lot. And that's why transplant teams really watch these people pretty much for the remainder of their lives, essentially.
And I think all of us, even folks that are not in the medical profession, know somebody that's had it.
That's right. It's a common procedure. Cancer therapy has come a long way. You're highly trained. And you have lots of different available options, including stem cell transplant, bone marrow transplant, which, was it really in its infancy. When I was a fellow, I trained some at Sloan Kettering, and, we saw children who had BMTs and a lot of adults with BMTs. And, it was quite the issue, especially with viral infection. It was always going to be fatal. Cytomegalovirus is one. So what do you do with them? You can try inhaled ribavirin plus or minus IVIG. Lung transplant recipients, again, high-risk population, ribavirin plus or minus IVIG. If you have other solid organ transplants, kidney transplants, heart transplants, you can consider oral and nebulized ribavirin as an option for those individuals. For some reason, there's less risk for them. And so what a little bit about ribavirin. Ribavirin is a nucleoside analog, and it's got in vitro activity against RSV. So has it been, again, do we know whether or not it's very effective in humans? We're not sure. Not routinely recommended for RSV bronchiolitis in infants and children. So we don't use it as a matter of routine for those children with lower respiratory tract infection, assuming they're immunocompetent. And IVIG may be warranted for the treatment of documented infection with RSV in immunocompromised patients. And then you have the monoclonal antibodies, which everybody now is aware of since COVID, when monoclonal antibodies were used extensively in patients who had potentially poor prognosis COVID infection, and usually used during a certain period of time before they became very ill. So you have palivizumab, which is Synagis. It's an RSV-specific humanized monoclonal antibody, can be used in stem cell transplants or hematopoietic cell transplants in adult recipients, but there's no data whether it does any good or not, or is effective. So if you have somebody who comes in and is really sick and they have RSV and they've had a bone marrow transplant, well, you're usually pulling out all the stops, and that would probably include off-label use of this agent. Prevention in infants and children. So standard practices to avoid infection, avoidance of infected individuals, hand washing, cover your cough, all that stuff. We discussed that already. Is that happening in daycare centers? I don't think so. Preschool, I don't think so. Kindergarten, I don't think so. In high school.
Nursing homes.
Yeah. We know what happened there with COVID. Even up into including high school, the kids are playing sports and, they're in basketball and they're, smashing into each other and they're in wrestling and, all sorts. And so even, cheerleading, right? That's a contact sport nowadays. And then you have nirsevimab, which is another monoclonal antibody. It's actually indicated as a preventative measure. So it's one dose and it's expected to provide protection for 5 months at the beginning of RSV season. CDC has specific guidance.
And those are for kids.
That's for kids.
Yeah.
So, if you have an unvaccinated mother get the vaccine during pregnancy and the child is born in the time frame, of, what do we say, November to April, it's a consideration, especially if, at 3 months, the child's going to go into daycare. But you'd have to discuss that with your physician, obviously, the risks, the benefits, and also stay within CDC guidelines. And they are extensive. I looked at them or couldn't go.
Yeah, we'll be talking more about that population in another podcast.
Okay, great. Because it's an area that, remember I said, you don't have one without the other. They're both linked.
No, they're connected.
They're all connected. We have vaccination in. So that's really the best preventative measure that we have. There are no current vaccination recommendations for children other than vaccinate mom when she's pregnant. Right now, pretty broad. Again, we discussed that adults over 60 years old or with chronic medical conditions, namely primarily cardiopulmonary disease or immunocompromised individuals. Those would be the ones who should be vaccinated. Then that's specific. The vaccines are new. Just got released within the past 6 months. And the CDC is pretty broad on who gets vaccinated. Healthcare providers, obviously, we discussed that. Teachers consider that. Daycare workers consider that. I have pretty much taken a similar stand on this as I did with pneumococcal vaccination. In other words, if you're a diabetic, with my critical care background, I think of every diabetic I ever treated in an intensive care unit who had DKA, which, in our era was primarily insulin dependent diabetics. We're now seeing DKA in middle-aged type 2 diabetes. I mean, that's like a new frontier in diabetes care and disease. So I would extend this, although it's not written anywhere. I would make the suggestion to my patient. Obviously, if you're 48 years old and you have COPD, I'm telling you to get an RSV vaccine. If you're, 24 years old and you have insulin-dependent diabetes mellitus and you're DKA prone, I'm telling you to get an RSV vaccine. If you're, got chronic kidney disease, you're going to get the vaccine. And I don't know what nephrologists are up to.
So is it a one-time vaccine?
One-time vaccine. We'll talk about that. If you have neurodegenerative disease, specifically making that recommendation, especially things like ALS, muscular dystrophy,
myasthenia.
Anything that might cause any respiratory insufficiency. Right. If I can link that problem to your lungs, I'm telling you to get a vaccine. So there are two. The trade names are Brisvo, which is Pfizer's vaccine, and then you have Arexvy, which is GSK's vaccine. And so recently released on the market, both pretty much simultaneously. Brisvo, which is the Pfizer vaccine, is licensed and recommended for pregnant women during weeks 32 to 36 to protect infants from birth to 6 months. So that's what OB docs need to consider and probably recommend. Arexvy doesn't have that recommendation. That is like a big issue because it involves finances, but I'm sure they're doing this trials. So that doesn't have the pregnancy indication. And both of these vaccines are pretty much made the same way. So it's not a messenger RNA vaccine. I know now we have this vaccination hesitancy because of everything that happened with COVID. And there's a lot of mistrust in vaccines now. People don't want to get their flu vaccines. People don't want to get their pneumococcal vaccines. And people don't want to get their shingles vaccines.
People aren't getting their children immunized.
Right. They're not getting their children
at the rate that we had seen before.
Right. So now I just saw recently where because of the whole COVID debacle, parents aren't getting their kids vaccinated for the measles, which has been around since the 1960s.
5 cases of measles in the Philadelphia area recently.
And in groups where vaccination is not common, specific religious groups like in New York City, there was a big outbreak of measles a few years ago with about 9 deaths. But this now fear of vaccination has become a problem because I think we may see a measles outbreak here at some point in the near future.
Well, we've gone from, because of the hesitancy, diseases that were close to being eradicated,
right,
to now a resurgence of them.
So proteins are expressed genetically engineered. Basically, they're RSV A and B is what you get. It's a recombinant protein vaccine, which was basically an instant. Because prior to that, what did they do? Slaughtered cows and slaughtered pigs. And they took their pancreas, they crushed it, they squeezed the insulin out. That's how you got insulin.
Yeah.
But the ability to make insulin and make human insulin was a huge advance. And I'd read about it, and I asked one of their representatives, are you people working on, human insulin, genetically engineered? They use bacteria.
Yeah.
And the guy says, we really can't comment. And within a year, it was on the market. And this was a huge step forward. I mean, it made a lot of other things very possible.
And that's in our lifetime. That's our practice life.
So
it's amazing.
Yes, we have seen amazing things. We've lived in very interesting times. And then getting back to the vaccine, you got to get it every year. Right now, it's a single dose vaccine. And that's what's recommended by the CDC. So you don't get it repeatedly like flu. Again, the virus doesn't change. And my thoughts are this: why do you always get reinfected with it if you've had it once? And does your immunity wane over time? And how is the vaccine different than the actual infection? And at some point in time, are they going to recommend it on an annual basis? And are they going to combine it with the flu vaccine? The good news is they don't have to change it.
And now we're going to switch gears a little bit. I'm here with Dr. Grant Shermer. Dr. Shermer, I'm going to ask you to introduce yourself to the audience. Tell us a little bit about yourself, and then let's talk influenza.
All right. So, my name is Dr. Grant Shermer. I am a hospitalist at Penn Highlands in Du Bois, Pennsylvania. I am a graduate of Lake Erie College of Osteopathic Medicine and did my residency at Penn Highlands in family medicine.
Being compared to pre-pandemic times, we've noticed that the immunization rate for influenza has significantly declined, and it's not nearly what it was pre-pandemic. That's a concern. Can you share with us a little bit about influenza and what tools we have to help protect us?
Sure. So, I think we're all relatively familiar with influenza because it's been around, our whole lives. But really is, if we go back to the basics, it's an acute respiratory illness, which is caused by influenza A and B viruses, but sometimes rarely C viruses as well. We don't think of that one as much, but we usually see the influenza A's and B's. Influenza A is the virus that is known to cause flu pandemics. And, we're very familiar with pandemics at this point because we just had one, but that is essentially when a virus emerges that infects people and has the ability to spread efficiently. And people really do not have an innate immunity against that virus specifically. But I think to kind of be on another point, it would be interesting to discuss influenza C because we don't hear about it that often. And that's an illness that does go around, but causes a very mild form of influenza, and it is not a cause of human epidemics. And then there's actually, I thought was an interesting point, in influenza D, but that causes infections more in animals. But the ones we're mostly going to be discussing today are influenza A and B. And it does cause outbreaks worldwide. Really influenza affects everyone. And it occurs typically more in the winter seasons in temperate climates, but it can, like I said, occur really anywhere. And the flu does change every year, which is why, we think about vaccination with the flu. And that changes because of, if you recall back to your medical school days with drift and in severe cases, shift. And antigenic drift really is when you have these mild mutations of the hemagglutinin and neuraminidase proteins on the surface of the virus, which is what our body can make an immune response to. So those are our antigens, and our immune system must recognize those. If we don't recognize those, then we can't create a response to it, which is kind of where the vaccine comes in. But then there's that also more severe change, which is called antigenic shift. And that's when you have those proteins that come from some type of interaction with an animal typically, and a new virus is really formed, which are new proteins to humans altogether, which is why they're typically much more severe. For example, if you think back to the H1N virus specifically. So that's kind of a little bit of the overview.
So these viruses change, so that necessitates us needing that flu shot every year. But sometimes that flu shot doesn't quite hit the mark.
It doesn't. Yeah. So, basically the flu vaccine is something that is a little bit estimated each year, so it's not a perfect science because we cannot predict those antigenic shifts and drifts. So the way that they really go about making those formulations is by taking the strains that are circulating, and this is done by both the CDC, World Health Organization, some independent laboratories, both in the United States and globally, and then also academic labs as well are involved in this process. And they try to predict the strains that are going to be coming out in the next few years. And what they do is take 2 strains of influenza A, both H1 versions and H3 versions, and then they take influenza B, 2 different strains of the Yamagata lineage and Victoria lineage, and they take those and try to estimate the upcoming strain and adjust the vaccine for that. So naturally, it's not going to be a perfect science, but the hope is that it would be close enough that you would have immunity to the upcoming strains. And then, there's also some thoughts on herd immunity and things, which we could discuss later as well.
So you have a whole bunch of different organizations coming together to decide what should go into the flu vaccine for the upcoming or the next season. But we have a lot of manufacturers that make the flu vaccine. Are all the manufacturers bound to use those combinations?
Not necessarily, there are different ways of formulating the vaccine. We have egg-based, which is the most common and really the most prevalent that we see, but there are other ways that you can create the vaccine, and it's the cell culture-based and recombinant-based. Typically now, though, most of the vaccines are egg-based. It seems to be the easiest way to reproduce the vaccine, and there are both inactivated vaccines and live attenuated vaccines. And the live attenuated version are the nasal ones. The inactivated vaccines are the shots that we typically think about.
Grant, there's been a push for certain age groups to get a higher dose flu vaccine. Can you comment on that a bit?
Yeah, so there are populations that are of higher risk, so we know that the populations who are at highest risk of complications or severe illness from the flu are children less than 5 years old, but especially less than 2 years old because they're still building their immunity. Adults greater than age 65, pregnant women and those up to 2 weeks postpartum, residents of nursing homes and long-term care facilities, and often these are people, who are greater than 65, but not always, and then minority populations, including non-Hispanic Black people, Hispanics, Latino, American Indians, and Native Alaskan persons. So there are those people who are at even higher risk compared to maybe their peers.
Do they think those other populations, what we're referring to as the minority populations, do we think that they don't mount as great of an immunity, or there's something biologically different there that causes that?
I don't know if that's fully understood yet, but I know we saw it at least during the COVID-19 pandemic that these were the same populations who were. So I think that there's some belief that there's probably a genetic component to the immune response, but it will be very interesting, in the future to see what really is the cause of a lot of that. But kind of going back to your question of the higher dose, so if we think about those who are recommended for the higher dose of the vaccine, it is typically some people that fall into those greatest risk population.
Very good. So, Grant, what are you seeing right now in the hospital? Are you seeing a surge of influenza and in the outpatient setting?
Yeah, we have seen a lot of influenza A and an occasional case of B. Typically, when we think about it, it's the more severe cases of influenza are A subtype, but B can be implicated as well in some scenarios. But typically what we're seeing is a lot of co-infections with the influenza virus, or complications of it. That's a lot of time the patients who are getting admitted to the hospital. So when we think about co-infections, there's one big one that, at least from a hospitalist standpoint, that we worry about, and that's superimposed bacterial pneumonias on top of influenza A infections typically, but like I said, sometimes B. And there's a few classic kind of hallmarks that can come with co-infections. So the first thing is bacterial pneumonia will often happen just within a few days of onset of the viral infection. So there's two ways that may happen that we see. You might see some minor improvement for a few days and then a double worsening, what we think about, even with other type of bacterial infections. But the other is if someone has a persistent viral flu infection and that is not getting better within 3 to 5 days, you may want to start worrying about bacterial co-infections. And interestingly, still the most commonly implicated bacteria in these infections is strep pneumoniae, which is, the most common offender of bacterial pneumonias, but there are other things that can cause bad pneumonias as well, which would be, staphylococcal pneumonias and whatnot, but it is still strep. So you still need that typical pneumonia coverage. But we have had some cases recently of co-infections with other viral infections, such as COVID-19, so we are seeing those two viruses hitting people at the same time. And there are a lot of complications with getting these infections.
And we're also seeing a combination with the RSV, hence we're testing for it more. It's probably there forever.
We are now picking up on that more, but certainly co-infections with that as well.
So, Grant, let's talk a little bit about what treatments we have. Certainly for the co-infections, you treat the co-infections, but for influenza, what can one do for that?
Yeah, so I think the first thing is prevention. We always have to think about prevention, and that is with the vaccine, and then obviously there are other things you can do to minimize your risk, hand washing and whatnot. But really the most important thing, I think, is the vaccination, so prevention is really somewhat of the cure. But there are indicated medications, for the influenza infection. So I think it's easiest to break it down into both an inpatient and an outpatient setting. So if we talk first about maybe the outpatient setting, so the primary treatment really is oseltamivir, or, there is a brand name for it, Tamiflu, but for the sake of this podcast, I'll refer to it as oseltamivir. So if a patient comes to your clinic, you suspect influenza, then really if they have had less than 48 hours of symptoms, then the oseltamivir is indicated. If they have had greater than 48 hours, then typically it is not indicated to treat the infection. And there's some reasons for this. But if the patient is severe in the outpatient setting, that they're having respiratory distress, abnormal vital signs, or any complications of it, then they should be sent to the hospital, obviously, But the reason why that, this timeline is so important is because there have been some studies done about, the benefits of receiving oseltamivir as an outpatient. And in the most recent 2024 systematic review, there was not a reduced risk of hospitalization when given. And it was not associated with a reduced hospitalization, especially with groups age greater than 65. And there are some risks to the medication, which include nausea and vomiting. There were some prior meta-analyses performed back in 2015 that did show, though, that patients treated with oseltamivir had a shorter time of symptoms, and it could, kind of expedite that healing process to some degree. And there were fewer lower respiratory tract complications in need for antibiotic treatment. So there are certainly benefits to it if you catch it in the first 48 hours. From the inpatient setting, there are pretty much the guidelines say, to summarize, if they come to the hospital and they have influenza, it's best to treat it, no matter what the timeline is. There are a few reasons for that, and the evidence really comes down to decreasing mortality. So there has been a shown mortality benefit to giving the antiviral treatment when patients are in the hospital. Any patient that presents with influenza, you would treat in the hospital. And that is if they're able to take oral medications, oseltamivir, but there are two parenteral medications that can be given as well. and those are peramivir and zanamivir. With those, I won't go into a lot of depth because they are less commonly seen. I would just recommend if you are planning to use them to look them up, because based on, different guidelines, what UpToDate says and whatnot, the dosing may be adjusted based on your clinical scenario.
So, Grant, what flu symptoms are you seeing more than not this season?
Yeah, both upper and lower respiratory, sore throat, congestion, and sometimes people may complain of sinus symptoms, but often cough, body aches, myalgias, those are the typical ones. In the hospital setting, the ones who are getting admitted, we're seeing a lot of, unfortunately, the complications, which can include anything from myocardial infarctions, myocarditis, myositis, rhabdomyolysis, CNS complications, which include, and that is a very common one that we see with influenza A. And then really the big ones are exacerbations of underlying diseases as well, especially including COPD. We're seeing a lot of that.
They're outpatients and they have flu symptoms and they call in. What can you tell them? How long can you tell them to expect to be sick?
Yeah, you should see improvement within 3 to 5 days from, typically their onset of symptoms, but really symptoms can last up to a week or 10 days, and they should be improving by that point, but you could suspect a solid probably 5 days of symptoms as an outpatient, especially.
So you're going to encourage, of course, supportive measures, Tylenol or ibuprofen for fever, cover your cough, wash your hands, vaporize your air, and stay away from other people.
Yes, absolutely. And, certainly there are things you can do to help yourself feel better. And, that's kind of on a case-by-case basis, depending what your contraindications are. But yes, there are a lot of other things we can do other than, the indicated medications to help.
And then there's always those, if this doesn't happen, then get yourself to the hospital for evaluation.
Absolutely.
Grant, is there anything more you'd like to share with us about influenza?
Well, yeah, I think there are a couple other interesting things. One is the changes with the flu vaccine about, who should get the vaccine and who should not, and there was always this idea about egg allergies, and the guidelines really have changed from the CDC in 2023-2024 season about those egg allergy guidelines. So really the new guideline says that people with egg allergies may get any vaccine if it's egg-based or non-egg-based that is appropriate for their age and health status. Previously, it had been recommended that people with severe allergies to eggs, those who had any other symptom other than just hives, be vaccinated in an inpatient or outpatient medical setting. But in this year, additional safety measures were no longer recommended for those people. All vaccines really should be given in a setting where allergic reactions could be dealt with quickly. So that was a new guidance from the CDC that I thought was interesting this year.
So who should get the flu vaccine?
Yeah. So, really everyone greater than age 6 months, so the only people who it's not indicated for are children who are younger than 6 months. They're too young. Or if you did have a severe life-threatening allergy to an ingredient in the vaccine, other than the egg proteins now, or a history of Guillain-Barré that you may not be a candidate to get it. But other than that, pretty much everyone else relatively falls in the category of, getting the vaccine.
Okay, so severe allergy to a component, history of Guillain-Barré, those are pretty much the folks that should kind of steer away from the flu vaccine and certainly steer away from anybody infected with the flu.
Yes. Yep. Absolutely.
Anything else?
No, I think we should just give a plug to OMT. If we think back, I know I always heard a story when I was in medical school about the success of OMT during, the influenza pandemics years ago. And that's where a lot of DOs had found some success. So I think that in an outpatient setting, it's probably most appropriate. But if someone does come into the clinic and has flu-like symptoms, there are a lot of OMT maneuvers that are focused on enhancing our immune system or, lymphatic system and whatnot. I think that should not be forgotten as well.
When we enhance our body's lymphatic system and immune system, we allow our bodies to heal itself.
Exactly.
So one of the things that I used to teach my parents, as well as my younger patients that would have the sinus congestion and the ear congestion, are some of the manipulation things they could do at home. The massage underneath the eustachian tube, the gentle massage of where the nerves come out just above the eye, and some sinus pressure points. What other things can you use more for the chest? What would you recommend?
Think about one thing, rib raising could be of benefit. The other thing could be lymphatic pumps. There's the Miller lymphatic pump and whatnot. And really everything to kind of help, the thoracic inlet release to, open up the inlet for the thoracic duct, really to keep, just like you said, keep the lymphatic system flowing so that our bodies are able to heal themselves,
The lymph pump is really easy to teach a family member to do for somebody too.
Yes, absolutely. Or even I think you could probably teach families to do the thoracic inlet release as well. So
very good. So Grant, thank you for joining us today. We appreciate all that you do and all that Dr. Aluzzi does to not only care for our patients, but educate our patients and educate each other.
Yeah, thank you again for having me on today.
This has been another episode of the POMA Does podcast. This podcast is eligible for CME credit. To claim your credit, please go to the website where you access this program or to poma.org, log in, and attest to your viewing. Thanks again, and stay healthy.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube. Or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.